Now, Mr Wagner.
Thank you. My lady, good morning or good afternoon. I act for clinically vulnerable families alongside Hayley Douglas and Margarita Cornalia, and we're instructed by Kim Harrison and Shane Smith of Slater and Gordon. In this module, CVF will give a voice to a group which continue to be impacted by both the virus itself and the UK's response to it, but who have been largely forgotten since the inaptly named Freedom Day. And one of the main ways it will do so is through the statement of CVF founder Lara Wong, which will be followed by her oral evidence next week. And I won't attempt to summarise that statement here, but commend it to you and to the public. As the inquiry has progressed, CVF has distilled its overall position to three basic principles: safety, support, and status. And that's how I'll structure my submissions today. First, safety. In order to keep those who are most vulnerable to COVID-19 and to other pathogens safe, physical environments must be made safer and more resilient to outbreaks of infectious diseases. For clinically vulnerable people and households, the impact of the pandemic is ongoing. And this is because many indoor environments remain unsafe against infectious diseases, particularly where transmission is airborne. The withdrawal of protections associated with Freedom Day and living with COVID policies did not necessarily go alongside a reduction of risk for those at heightened susceptibility to severe disease. Instead, those policy decisions shifted responsibility from systems to individuals in circumstances where people lack the tools to assess their risk and protect themselves effectively. And this is especially important in relation to shared indoor air, where structural measures such as ventilation, filtration, occupancy, and respiratory protection, over which individuals have very little control or specialist knowledge, determine whether an environment is safe, far more than individual behaviours. This is a fundamentally important point for CVF, and I want to put it metaphorically in neon lights in these submissions. Clinically vulnerable individuals cannot reliably make themselves safe in indoor settings. The responsibility falls on those who control the environment, such as employers, those who run cultural settings, indeed this inquiry itself. And this especially applies to structural factors like ventilation and policies. And until the people who control the environments take responsibility or are forced to take responsibility by government, clinically vulnerable people will simply not be safe. They cannot pull themselves up by their own bootstraps and should not be expected to, no more than other people with protective characteristics. To pick up on the analogy Mr. Weatherby Casey borrowed from the Joseph Rowntree Foundation, we were all in the same storm but not in the same boat. Clinically vulnerable people in unsafe workplaces, social environments and the like are in a leaky boat without any way of bailing out the water. And it should not be their responsibility to build a safer boat, especially while they're in it. Just to give some examples which reflect the topics being investigated in these modules, in this module. First, in the workplace, the absence of enforceable rights to COVID-related adjustments continues to leave clinically vulnerable people exposed to danger. There's been a regular refrain during the pandemic, often repeated in this inquiry by witnesses, that clinically vulnerable people were fearful or nervous or anxious to return to the workplace. It's very important to CVF that the genuine risk to clinically vulnerable people is not made out to be a pathology. And this is part of the point I've put in neon lights. There is a genuine risk because many indoor environments are unsafe for clinically vulnerable people. Safety at work is determined by real, objectively measurable factors such as system design. And this includes ventilation, density, access to respirators, access to remote work, the availability of sick pay. It's not merely about individual resilience. Similarly, in healthcare environments, the removal of universal masking and the absence of consistent airborne infection control deter high-risk patients from accessing necessary care. This leads to delays, cancellations, and the deterioration of health conditions, as CVF's polling and member accounts show, and you have heard, my lady, from CVF in Module 3. In cultural settings, the inquiry's Cultural Institutions Roundtable Summary Report says that there has been a variable retention of protections in cultural settings. It says, representatives describe sustained changes in audience behaviour after reopening and highlighted that clinically vulnerable and older audiences were less confident about returning, particularly for live events and indoor settings. But they were less confident because it was unsafe. CVF's witness evidence records exclusions from public and cultural life as protective measures were withdrawn. And again, clinically vulnerable people cannot reliably make themselves safe and shouldn't be expected to. Faith communities provided online and outdoor services that were particularly valuable to vulnerable congregants, but many of those were taken away and barriers to safe participation persist. One CVF member reported that, and I quote, "Our church refused to consider improving ventilation due to perceived discomfort from other worshippers, which was prioritised over the safety needs of vulnerable people. We offered to fundraise for HEPA filters to make the worship space safe for elderly and vulnerable people, but the PCC obstructed this. They prioritised the comfort of others over our safety, even knowing our son had nearly died from COVID. It was a moral injury." This emphasis on comfort, my lady, really comes down to a cultural issue, that people do not necessarily see the issues that clinically vulnerable people face, and therefore they don't expect to have to make any accommodation for them. And that will not change unless the culture changes. Finally, in the justice system, as in-person hearings resumed, CVF members reported reduced flexibility for remote attendance and pressure to remove masks, including in circumstances of severe immunosuppression or significant caring responsibilities. And in detention and asylum settings, people with clinical vulnerabilities were often placed in accommodation without adequate screening or infection control. Staying on safety, another theme which unites all of these topics is that stigma and hostility intensify the risks faced by clinically vulnerable individuals. And this goes back to the point I was making about culture. That stigma and hostility compounds the harms, especially to mental health. CVF's polling found a rising proportion of respondents reported mask-related harassment since 2022. Those reports increased from 48% in September 22 to 65% in January 24. CVF members describe being pressured by others to remove their masks and that they face verbal or physical aggression when adopting self-protective measures. The Key Workers Roundtable Summary Report, my lady, records abuse directed at public-facing staff around enforcement of protections. This stigma and hostility to clinically vulnerable people has to stop, but instead it seems to be getting worse. And again, it goes back to culture. And that's why CVF will invite the inquiry to recommend that public messaging clearly explains the protective benefits of high-grade masks for the wearer and the community, and explicitly recognising the right to wear masks in public services and workplaces. And CVF will also ask the inquiry to recommend regulatory guidance, for example, by the Equality and Human Rights Commission, that discourages blanket prohibitions and supports simple, proportionate adjustments. And on safety recommendations, CVF's overarching position is the only way to make clinically vulnerable people safe in society is structural change. Infection control must become a priority in healthcare and public services. Indoor air quality should be regulated in the same way that other important issues of public health are, with CO2 and air filtration standards, effective monitoring and enforcement for buildings that fail to meet these standards. Essential systems from courts to accommodation in prison settings, for example, must incorporate adjustments as a matter of course. They should not be special privileges. They are minimum conditions for equal access to society for those whose elevated risks are well established. CVF's second main theme is support. Clinically vulnerable individuals and households experience the pandemic harms more severely and more persistently than the general population. But the support response did not reflect this reality. CVF's evidence, including its 2025 Impact on Society survey, shows that risks and barriers such as unsafe health environments, lack of tailored mental health support, and weak employment protections, and persistent social exclusion converged with clinical vulnerability, and the effect was to deepen disadvantage. CVF's submission is that future planning should prioritise targeted support for clinically vulnerable people across all of the domains that Module 10 examines, which are in essence one domain, which is the social environments which clinically vulnerable people have to operate in to live a normal life. In this module, CVF will highlight a number of thematic issues identified by the inquiry in its provisional list of issues, and that are set out in more detail in our written submissions. First, that the mental health and well-being impacts on clinically vulnerable people were distinctive in both severity and duration, and they continue to be felt, which all demonstrates the urgent need for support. Second, financial stress and job insecurity, which were often interrelated for clinically vulnerable households, was a recurring theme. Third, intersecting vulnerabilities amplified impacts for clinically vulnerable people. To give a couple of examples, survivors of domestic abuse experienced heightened coercive control during the pandemic, with clinical risk weaponized to limit movement, deny access to care and support, and to isolate victims. And clinically vulnerable people within its immigration and asylum system, or in prisons or other places of detention, faced acute risks from settings where they had to congregate without adequate screening or protective measures. And so, CVF will seek to persuade the inquiry that support for clinically vulnerable people across each of the Module 10 thematic areas must be anchored in the realities experienced by clinically vulnerable people. Finally, status. There were significant issues at the height of the pandemic around the correct identification of those who were particularly vulnerable to COVID-19. You've already heard from CVF in previous modules about the issues of making a distinction between clinically extremely vulnerable and clinically vulnerable in relation to the support that was offered to CEV but not CV. And for some, that designation came to an end prematurely. How can we prevent these issues occurring again? As the Module 1 report said, preparation is everything. But it's all very well saying that we should prepare better next time. You simply cannot prepare without adequate data. Data was not collected during the pandemic to properly capture clinical vulnerability and the experience of clinically vulnerable people. For example, surveys carried out often did not collect data on clinically vulnerable groups. And Professor Majid has said in his statement to this module that clinically vulnerable populations relied on fragmented primary care records, leading to gaps in real-time monitoring. And your systemic evidence review, my lady, also identified a lack of sufficiently detailed or disaggregated data on CV and CEV groups. And CVF has sought to fill this gap, but as a tiny charity, it's unable to do so across the board. And steps must be taken, we say, to address the gaps in data, including routinely disaggregating data by factors including clinical risk groups. And And CVF very much supports recommendation 9 of the Module 2 report, that the UK government and devolved administration should agree a framework to identify those at most risk of being infected and dying from a disease, and the potential impact of mitigation steps will have on those groups. But CVF requests in this module the inquiry goes further to protect CV people, not just during pandemics, but in peacetime too, when infectious disease in public settings is still a serious, life-limiting issue for clinically vulnerable families. And finally, CVF again implores the inquiry to consider recommending that clinical vulnerability becomes a protected characteristic in the Equality Act, a huge structural gap which will go some way towards changing the culture and also the reality of social settings for clinically vulnerable people. And in parallel, the Equality and Human Rights Commission should update its statutory codes of practice to reflect the importance of protecting clinically vulnerable people. In conclusion, there are no easy answers to the issues identified in this module or indeed this inquiry. But if you focus, my lady, on safety, support and status, that will go a long way to protecting clinically vulnerable families now and in the future.
Thank you very much indeed, Mr. Wagner. Very helpful.